Now I would like to invite the panel so that we can take the questions. We have Frederick and Andrew available, but Professor Munasinghe is not here, but there are a few questions that I'm sure we can all answer together. So, okay, welcome back. Can you hear me? You can turn your microphone on.
Yeah.
Quite a few questions. And before we go on to the questions specifically for you, Andrew and Frederick, there are a few common questions about preoperative assessment, and there have been some suggestions. I understand that people who are asking this question obviously are quite experienced in the field of preoperative assessment, and they do it and they're on their they have set up their clinics, pre-op assessment clinics. And some of these questions are quite interesting. And I would like to start off. There is first question was about, would electronic self-assessment improve the inpatient pathway? At what point should they be introduced in the referral? So electronic self-assessment. Do any of you have anything to say about that, Frederick or Andrew? Would you like to say, Andrew, about electronic self-assessment?
I mean, I think I don't do much pre-assessment, but I think that electronic pre-assessment is probably almost inevitably going to come, and I think that it won't just come from the patient. So I think once our systems are integrated between primary and secondary care, and now that we've moved to the ICS type structure in the UK, there's opportunities to do that. So data will come directly from the GP, from the surgical clinics, and also from the patients. And I think that we will be getting a lot of data directly. So there's no reason that you couldn't, sorry, they're still running around upstairs. There's no reason why you couldn't get a text or an email to your patients before they come, and they sort of pre-fill in their pre-assessment data. And I think Ramani was alluding in her talk to some challenges with that, and maybe some suggestions that maybe the elderly are maybe not as computer literate as the younger, but they're the people who were going to be coming mostly for pre-assessment. And I think that there are challenges, but they can be overcome, and we can help people through that.
Yeah, I agree. I think that would make it easier, and that can be done as early as possible, as you pointed out. The general practitioners could be giving us a brief summary of the patient, which they often do when they're writing to surgeons, and they could say, but if they can identify areas where patients can be optimized, that would certainly help. But I think electronic self-assessment would be a good way forward, and that should be done as early as possible, is the answer. Frederick, do you have any views on that?
Yeah, I'd like to add something. I think electronic assessment, I mean, you could understand it as well. It's auto assessment. What I mean is that more and more people are measuring the heart rate or their SpO2, you know, patient with chronic respiratory disease. Now we have multiple tools are becoming available. They are not all accurate. Most of them are not even medical grade products, but we know patients use more and more these kind of tools, so they have a better knowledge of what is their baseline blood pressure, for example, what is their baseline heart rate. So I think it's a way not only to probably better predict the risk of individual patients, but it's also a way for us to, I would say, better define what should be the physiological target during surgery and after surgery. So just to summarize, you know, a really an ideal way to really individualize management. I think one of the best examples is blood pressure management. You know, we all know that when we measure the blood pressure right before anesthesia induction, it's not a good reflection of the normal, usual blood pressure in a given patient. So if patients monitor their blood pressure, not continuously, but from time to time with optical bracelets, some of them are actually approved for medical use today, they know what is their normal blood pressure. And so that's very valuable information for the anesthesiologist in charge.
So it kind of establishes a baseline on which we can further compare and build. So I think that's a very good way of doing that. There is one more question. This was about with Preeti Morzaria. She was questioning about pre-screening, and she says, won't this delay and potentially increase waiting time for surgery. I think Preeti was probably referring to pre-screening as pre-assessment. I think pre-screening is done at a much earlier stage, where the surgeon looks at, decides on surgery, and at that very point, we are trying to figure out what is the best course for this patient. I think so that is done much earlier. I think that is the answer. That's what I feel. Andrew, what do you think? Pre-screening is quite different from pre-assessment.
Yeah, it's coming earlier in the pathway, and I think that the key thing is what Ramani was trying to say, is that in that Super SNAP study that she undertook with our COA, was that there was a really high rate of on-the-day cancellations, and a lot of those were because of things that could maybe have been managed better earlier, so hypertension, diabetes, and if you're only seen in pre-assessment clinic a few days before your operation, there's not always the opportunity to correct those things, but if it's 6 weeks, 8 weeks before your planned date of surgery, then there may be the opportunity to do that. And sometimes, we don't necessarily cancel people from pre-assessment clinic. We hope that things might be better on the day, but then they're not, and then they do get cancelled. So having that stage, before gives us more opportunities. It will require investment in time, money, personnel, but fingers crossed, it will be of benefit.
I think so. Frederick, I think you have experience outside UK quite a lot. Have you had any experience of this in any other part of Europe?
You mean regarding preoperative assessment?
Yes.
No.
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 Yes, about pre-screening before the pre-assessment.
No, I'm sorry.
No, so that's good. I think pre-screening is a good idea. I think that's a new development that will be coming up. So we are very proactive and identify problems and then refer the patients or put them through proper channels, and that will minimize cancellations. There is one question from Professor Venkatapuramurthy. I think it's a suggestion and then a question as well combined. He said, in his experience, NSQIP score is the most useful risk predictor for any surgery, and it is better than SORT, which I think is what some of the studies say. But I think NSQIP is basically American, validated there. SORT is UK based. And from what I know, SORT is more user-friendly than NSQIP. NSQIP has more questions in it. And then also SORT being quicker, and also the way Professor Munisinghe presented it, you could see that actually once you are done the SORT, there are other questions that drop down, and many more questions are asked. That brings it almost close to NSQIP at the end of it, once you begin to answer those questions. And then at the end of it, the clinician also puts in his experience, his evaluation as well. So combining all those, you can find that the SORT would be very user-friendly, easy to use, and it bring it on par with NSQIP. That's my view. What do you think, Andrew and Frederick?
Frederick looks like he has a comment.
Frederick, what did you say?
Yeah, I just wanted to make a comment about all these scores, which have been proposed to predict complications, outcome, mortality. My comment was very often less is more. So you mentioned the NSQIP. So I'm sorry, I say NSQIP. I don't know, it's NSQIP.
Yeah, that's fine. Yeah.
But so, for instance, I like very much what has been developed by Professor Ramani, because the SORT score, the SORT score is very simple, very easy to calculate. And I think the predictive value is comparable, if not better, than many complex scores. There are even today machine learning algorithm crunching a huge number of data to predict post-operative outcome, blah, blah, blah. But I have in mind a very interesting paper published, I think, a year ago by the team of Paul Miles, published, I think, the British Journal of Anesthesia, comparing different scores and the subjective assessment of anesthesiologists at the bedside. And their performance was comparable to these super sophisticated scores. So I think, sometimes it's good to remember that less may be more.
Yeah, I agree. I think in the present situation where we are so very overwhelmed with the workload that we have, going through elaborate scoring systems is just not going to be very useful for us. I think the SORT will do very well with all the things that Professor Murli has suggested, which I think it will work very nicely together, is my view as well. So there is one more question. This is about risk prediction. 30-day mortality is less relevant for majority of patients, and the morbidity relevant for the patient is not necessarily predicted by these models. That's fine. But I think the 30-day mortality is how the government compares the performance of different trusts, and that's how it works in the National Health Service. It is perhaps you can look at survival after 30 days as well in certain situations, in special situations. But by and large, 30-day mortality is what the government is currently using for comparing hospital performance, surgical outcomes, and so on. So that's why the 30-day mortality is probably relevant for this particular assessment. What do you think, Andrew, Frederick?
I think, 30-day mortality, 1-year survival, and these things are all important, and they're important for the overall running of the hospital and health economics. I think what we have seen in particularly research studies now is a focus towards patient-reported outcome measures and what actually matters for the patient. So it's, am I in pain? Am I able to get up and about? Not what's my 30-day mortality, but how many days at home do I spend in those 30 days, or do I go back to the setting that I was in? So if I was home, do I go back to home, or do I need to go to a rehab type setting for a period? And I think they're the key things that matter. I think high risk surgery is clearly high risk, but there's a lot of what we do where you'd be very upset if the patient was still there 30 days later, or if the patient didn't survive. And I think teasing out these patient-reported outcome measures are the things that really matter to patients now.
Frederick, any comment on that? 30-day mortality?
I fully agree. I think it's very important to keep in mind that functional recovery is very often more important for patients. And, we should not forget that, functional recovery.
And Frederick, I would like to ask you, do you think the private sector is any different when it comes to how the patients should be treated in the private sector? I personally think it should be no different from what we do in the government sector. They should get the same level of care, same level of preoperative assessment and intraoperative monitoring and postoperative care. What do you think?
I think patients should benefit from, what's best for them should be offered both in the public and the private system. But I know it's not always the case. I also know it's not always better in the private sector, at least in France, a country I know pretty well. So that's all I have to say on that.
Okay, now we come to some questions for you two, specifically for you. I think we exhausted all the questions for Ramani now. It's about impedance plethysmography from an ECG, may be more widely available than capnography. Many colleagues may be unaware of the facility, for example, in the recovery, endoscopy, or radiology suites. That's why this is a suggestion. I suggest the AAGBI should consider including the use of this option in its recommendations. So can you enlighten us something about impedance plethysmography, Frederick?
For post-operative monitoring, I understood your question was more for during the procedure, no?
Somebody wants to know about impedance plethysmography from an ECG. Is there such a thing? I don't know. You did talk about plethysmography in your talk. I think something about
plethysmography, but you mean pulse oximetry. Pulse oximetry. Yeah. So pulse oximetry. I mean, it's. I'm not sure I understood the question about pulse oximetry.
Impedance plethysmography may be more widely available than capnography. I know this is just a suggestion. I'm not sure if that's correct, but.
So what I can say is that, for research at least, capnography remains the reference for monitoring respiratory rate. But it's mainly for research because we all know that. And once again, I have in mind spontaneously breathing patients who have been extubated, who are awake, okay? Andrew will probably comment on what's happening during surgery, during general anesthesia. But for awake patients, in most studies investigating the value of new tools, new technologies to monitor respiratory rate continuously, we consider capnography as a reference. Now in practice, we all know that capnography is very often a challenge because patients do not always tolerate the nasal prongs because it's not a mobile solution. And so we are all interested now in using mobile solutions so that patients can mobilize as soon as possible. We know early mobilization is a key element of enhanced recovery programs. So, capnography, once again, remains the reference to measure respiratory rate, but for patients who are stuck in bed and patients who accept their nasal prongs. And so that's, I think that would be my main comment regarding capnography.
So a question to Andrew regarding depth of sleep monitoring during anesthesia. There are different things available, isn't it? Any comments on that? What is suggested? What is the best? Do you think that should be used for every patient, whether they get total intravenous anesthesia or a inhalation or anesthetic?
So, I mean, I would like to say what is the best. I think most trusts use what they use and it's what they procured, and you're probably best at using the device that you're most familiar with. There is some evidence that's coming out suggesting that depth of anesthesia might be associated with delirium, particularly in patients who are frail or high risk. I think the balanced study that came out suggested that, if you have, and they looked at a cohort who had volatile anesthetic, I think, when, and they put BIS monitoring on, if your BIS was down at 30 for a long time versus 50 with a volatile anesthetic, then you had a higher rate of delirium in the lower BIS group. So I think that it's not clear to me exactly where we should target, but I suspect that there will be increasing amounts of evidence over time that we can use to refine our targets. I think things like the VITAL trial will be interesting because that will tell us, so that's in the UK using the PQIP cohort, which is volatile anesthesia versus total intravenous anesthesia. And I think that will give us lots of insights into these things when they do subgroup analysis, because TIVA versus volatile is not just about propofol versus gas in the UK. It's often processed EEG monitoring along with TIVA, and often, say, metaraminol or phenylephrine infusion. There's lots of TIVA. People think it's just propofol, but actually it's often a combination of techniques which may be superior to a standard volatile technique. So I think there'll be insight that comes from that, if that trial is positive, to suggest what are actually the things which are driving the benefit.
Frederick, do you have anything to say about this, or no? Frederick, do you want to come in on this question about monitoring, BIS monitoring?
BIS monitoring, it's not really for post-operative monitoring, so I prefer let Andrew comment on that.
Yeah, Andrew has just spoken about it. So quite a few questions. If you can sort of go through and see, there are more and more questions. I'm just looking at it. Andrew, you talked about hypotension during anesthesia, and now I personally, I keep mean arterial just above 50 in certain situations because the types of cases that I do, I require blood pressures, mean arterial pressure just to be around that. Otherwise, the surgeon will have a very difficult field. And there is so much talk about acute kidney injury and worries. What is your opinion about what can be allowed really? I know there is theory and the patient, there is always this worry about hypertension and what can be done about this. People use metronidazole infusions, some people use phenylephrine. What is your choice when it comes to management of hypertension intraoperatively?
Again, I think it's about your own experience and how you do things in theatre, and there's lots of options. I mean, my personal practice is that if I think that a patient is at high risk of having hypotension during a procedure, or if they're very sick, then I'll often, rather than having metaraminol drawn up at the side, I'll have it in an infusion pump, and I sometimes have it even running during induction to try and prevent those periods of hypotension. I think it's one of those things that, as evidence comes in the coming years, we'll know what the targets are. But again, it's probably individualized. And I think it's going to what Frederick was saying earlier, like, what is your baseline blood pressure? What is your risk? What is your risk of having cerebrovascular disease or dysfunction post-operatively, and that will drive how aggressive you are intraoperatively. If you're a frail elderly patient coming for a carotid endarterectomy, clearly blood pressure management is of utmost importance for you. But if you're fit and well, coming for an appendix in your 20s, then periods of hypotension may not be as deleterious to you.
Yeah. Okay. Frederick, Frederick, you can come in anytime you feel like saying something.
Yeah. Yeah, hypotension, it's I'm afraid we don't have enough time to discuss about intra and post-operative hypertension, but maybe just one comment. Of course, I fully agree when Andrew said that we need to try to individualize. We need to improve the way we measure the blood pressure of our patients before surgery. And I have in mind a very interesting study from the group of Bernd Sogel in Germany. So they monitor blood pressure during the night, days and weeks before surgery in patients undergoing high-risk surgery. And one of the key findings is that about 1/3 of these patients have a MAP below 65 millimeter of mercury, a threshold which is frequently used as, ooh, be careful, keep the MAP above 65. So 1/3 of these patients had a MAP at some point during the night below 65 millimeter of mercury. Some had even a MAP below 50. And of course, none of them woke up with organ dysfunction, right? So it's a way to remind us that individualization is probably the answer. Some patients may tolerate a MAP below 65. Other patients probably need more. So it's key, I think, first of all, as I said, to better measure the blood pressure before surgery, better estimate what is the baseline. It's probably also a plea to develop tools to assess tissue oxygenation, tissue perfusion during surgery, and then react only when a low MAP is really associated with a decrease in brain oxygenation, with a decrease in gut perfusion, and so on and so forth.
And I think we did touch on temperature monitoring, which is now a standard and everybody monitors the temperature. I think somebody had asked a question whether it actually, if we have low temperatures during surgery, does it worsen mortality, morbidity? I think the idea is to monitor it and maintain it within a reasonable length, because I think that the outcome is better with that. Are there any publications on that? I personally cannot recall any recent publications on that, but I'm sure it's recommended that patients maintain core temperatures close to what normally is. Is that right, Frederick? When it comes to temperature?
Yeah, once again, I'm more the post-operative guy. What I can tell you is that there are indeed tools today also to monitor skin temperature. So it's not perfect because it's not central temperature, but still you can look at trends. And when patients develop infectious complication, I mean, these wireless sensors measuring skin temperature continuously are probably part of the tools we could use or we should use in the future to detect infectious complication at a pretty early stage.
And also with TIVA, the standard for TIVA is a DOA monitor by depth of anesthesia monitoring, by whatever means, whichever BIS or whatever. So they were saying, should it be a standard? Yes, it is already a standard, my trust. Should the association impose it? I think in the TIVA Monitoring Association would, as recommended, that we certainly use depth of anesthesia monitoring. So that is already an existing standard, and that should be followed, and that's what most hospitals do. And this question is for both Andrew and Frederick, because this is between the two of you. It says, should there be a recovery room score before you transfer the patient from the recovery to the ward? Should we score them and say, well, they have reached this score, see, it is safe to send? Again, it is going to be time consuming. It is going to be a lot of paperwork. So do you think that's a practical thing to do? Andrew?
Well, most units will have some kind of recovery discharge criteria already. So whether you call that a score or criteria, I think most units are practicing that. And if you fall out with that, then in the units that I work in, they let the on-call anaesthetists know about it, and then you go and review the patient, and based on that, you then decide whether or not the patient would be safe to go to the ward or they need some degree of enhanced care. So I suspect that we might not call it a score per se, but I think that most units do that in some form.
Yeah. A question directly to Frederick Micard. This is to Frederick Micard about the problem of Bluetooth in monitoring pickup.
What?
Also, they use Bluetooth to connect. Bluetooth. About the problem of Bluetooth in monitoring pickup, which means sometimes the Bluetooth doesn't work, it doesn't communicate, doesn't pick up. And also the unreliability so far of wireless detection in the ward hospital setting. This is what makes me think we will solve these problems after so many years of trying to overcome these problems because of the failures.
It's a very good comment because, and I briefly touched that in my lecture, which is connectivity, and we all experience disruptions with Bluetooth headphones, for example. That's why some companies develop what I would call or would describe as medical grade connectivity protocols to ensure that 99.9% of the time we are sure that we get the signal. Otherwise, of course, I mean, it could be an issue if we think a patient is going well because we don't have any news, we don't receive any alert, but just the patient is disconnected from the system, is wearing the sensors, but the sensors are unable to transmit the information. So that's why I think for home monitoring, because it's another topic, but it's also an important topic because that's probably a way to discharge patients earlier from the hospital and then continue to look at them from home. So for home monitoring, it's probably acceptable to continue to use Bluetooth connectivity protocols because most of them don't need really continuous monitoring. Otherwise, I would say they should stay in the hospital. So Bluetooth, sometimes you will have disruptions, but if it's from home, at least you will get multiple snapshots, and then that's probably enough to get a fair idea if your patient is going well, recovering well, or actually deteriorating. In the hospital, I think it's very different. I think we need to offer our patients really continuous monitoring to be sure we detect clinical deterioration as soon as it starts to develop. And that's why I think we need to select systems using medical grade connectivity protocols.
Yeah, and also there's a question following on that, which is the information regarding post-operative continuous monitoring sounds fantastic, but how do you think we can practically implement that within the NHS? So because with all the cost constraints and all that, I think in your talk you mentioned that actually initially it may involve a cost, but in the longer run you actually get more benefit out of it and you get that money back. Is that right, Frederick?
Yeah, that's what we expect. First of all, I don't think we will need to monitor all patients. We can expect from a smart algorithm to tell us who are the patients at high risk of clinical deterioration. So it will be a way to select some patients in whom we will say, okay, then we are going to monitor vital signs continuously. For other patients, we will continue as we do today with spot check every 4 to 6 or 8 hours. So we are not going to monitor all patients continuously. Second, patients who are monitored continuously, yes, we can detect, or the idea is to detect at a very early stage clinical deterioration, and then most of the time we should be able to prevent catastrophic events, and so to prevent some ICU admissions, some cardiac arrest. You know, there are already 7 studies published demonstrating, I shared some of these studies in my presentation. So large prospective before-after studies, not randomized controlled trials, but implementation studies showing that after the implementation of continuous monitoring on the wards, it is most of the time associated with a significant drop in the number of rapid response team calls, in a significant drop in the number of ICU admission, cardiac arrest. There is even a study from the UK, from Chris Soubey, reporting a decrease in mortality. So of course, all these clinical benefits should be and will be associated with economic benefit. We need to connect the dots so that hospitals understand at the end of the day that the investment they may have to make at the beginning to make possible continuous monitoring of high-risk patients is going to be actually a very interesting return on investment, not only for their reputation and not only to offer better care, better quality of care to our patients, but also interesting from a financial standpoint. It should be the case.
Presumably there are other benefits. I mean, you know, on most surgical and medical wards in the UK, there's almost somebody continuously going around doing obs on all the patients. And if you're doing a lot of this remotely, you're freeing up some of those staff to do other things on the wards, and that presumably brings other benefits.
Yeah, there's a lot of interest. I think we have only 4 minutes. So I'll try to just ask this, that there is a lot of interest in this monitoring. The people are very appreciative of what about the webinar as such, and also they want to know how can they, whom can they contact? Is there a website where they can go to and find out? So probably if you have any contacts, if you can send it to us, we will try to put it on the association webinar and send it to the people so they can access what facilities are available and how they can go about improving this system. A lot of comments about how the GPs can actually get involved early on to help the system, which is very good. And there is more direct relationship between surgeons and anesthetists in the private sector, and operations can be expedited. I suggest NHS patients would benefit if they received the enhanced care available to private patients. That's what he was. I think that is one of the suggestions made, that I said that the NHS and private should have the same level of care, but he's trying to clarify that there is a more direct relationship between surgeons and anesthetists in the private sector, and operations can be expedited. That NHS should also have a similar system. I think many NHS do have similar systems. Then there is one question about transthoracic impedance and RR variability are principles which are utilized from calculate our respiratory rate, and this is available on most portable monitors in PACUs. I think that is only a suggestion. We don't need to answer it. Thank you to Dr. Burry for suggesting that. Let's look at the last. Momentary hypertension corrected by vasoconstrictors will not produce AKI. It is the altogether patient deteriorated physiologically. Yes, agree with that. Are we going to stop using nitrous and vaporizers completely in future? More than likely, I can say that as an association member, that we are trying to push out nitrous oxide. Desflurane is already out, and therefore we have only sevoflurane in our hospital that we are currently using. Other inhalation agents are going. So that actually is all the questions we have. There may be more questions. Some of the questions were repeat, so I didn't bring them up, but I think in general, we have covered all the important topics. So Andrew, do you have anything to say? And Richard, Frederick, one sentence each before we close the webinar.
No, it's a great pleasure to be here, and I think I've learned a lot about post-operative monitoring as well from Frederick, so thank you.
Frederick, would you like to say a last sentence?
I also just want to thank you, I mean, all attendees, and of course the Association of Anaesthetists for having me, and that was great. Thank you so much.